Alright, so we're going to look at some of the infectious diseases of the urinary tract. So this is going to include cystitis, which is a bladder infection, acute pyelonephritis, perinephric abscess, and asymptomatic bacteriuria. So let's quickly review the anatomy of the urinary tract. Of course, we all have kidneys, we all have ureters, which conduct the urine down to the bladder. We all have bladders, and the urethra in men is significantly longer than in women, and that's going to be important because that's going to make men less susceptible to urinary tract infection and women more susceptible. In men, there is a prostate, which of course is not present in women, and that prostate is a possible source of obstruction. So the prostate in men can, if the prostate is affected, if it's inflamed, can be a risk factor for a urinary tract infection. Okay, so the number one cause of UTIs is E. coli. That is by far and away the number one cause. Other causes include the other gram-negative bacteria, and in young girls, prepubertal girls, a significant cause is Staph saprophyticus, and that's just because of the chemistry of the vagina, and Staph saprophyticus can colonize and cause urinary tract infections. So, like I said, predominantly UTIs occur in women. If a man has a confirmed UTI, he should always be followed up with imaging for anatomical abnormalities, for prostate problems, and so forth. The major risk factors for UTIs include instrumentations, so that would be catheters or procedures that involve the urethra, immunosuppression, obstruction, so that could be like stones or prostate enlargement, ureteral or urethral strictures, again that's another sort of obstruction, and tumors, which is another obstruction. So the common symptoms, and these are going to be what I refer to as the UTI symptoms because they're so prevalent in patients who have UTIs, is dysuria, burning, frequency, and urgency. Dysuria is pain on urination. Burning is how that pain is described generally. Frequency is the need to go to the restroom more frequently to urinate, and urgency is that sensation of needing to urinate. In all women that have urinary tract symptoms, you should always consider cervicitis, particularly if they complain of vaginal pain or dyspareunia. So, cystitis. So this is a bladder infection. It's infection and inflammation of the urinary bladder. These are going to be patients that don't appear ill, but they come in generally to the clinic, but occasionally to the ER, and they complain of these UTI symptoms. It hurts to pee, I'm going to the bathroom frequently. When you do your physical exam on these patients, if you palpate just above the mons pubis or above the penis in the male, you will almost always get pain. So this is suprapubic tenderness, and this is characteristic on the physical exam of cystitis. A lot of times the physical exam will otherwise be normal, so that's something to keep an eye out for. Generally though, these patients don't appear ill, they very rarely have fever, and they will never have flank pain. So flank pain, what I refer to as flank pain here is costovertebral angle tenderness, and that's just pain on the flank and the back. And what you do is you just percuss the back right below the costal margin, and if they have flank pain, then you are not going to be diagnosing cystitis. So you cannot diagnose cystitis if they have flank pain. No flank pain is a criteria for cystitis as far as USMLE is concerned. So cystitis is generally sporadic in women. So some women are just predisposed to it based on various factors. Some women get it more frequently than others. That's just the way it is. It can be completely coincidental in women, but in men, there's always something behind it. So in men, it could be BPH, it could be catheters, it could be the practice of anal intercourse. You should always consider, if you have a diagnosis of cystitis in a man, you always need to consider what's behind it, because it's never the way it is in women, where women can get this like the cold or the flu. Men, there's something behind it. But in general, if a man comes in with UTI-like symptoms, you should always strongly consider alternative diagnoses besides cystitis. So something like prostatitis, orchitis, epididymitis, STDs, like gonococcal urethritis, or non-gonococcal urethritis, like chlamydia. The diagnosis is going to be made on urinalysis. So any patient who comes in with these UTI symptoms, the best first step in diagnosis is a urinalysis. It's cheap and it's easy. And if the patient has UTI symptoms and they have a urinalysis which shows greater than 5 on the white blood cells, that's a positive diagnosis for cystitis, and you're going to go straight to treatment. Other things that you may see on urinalysis are positive nitrites and a positive culture. But as long as you have white blood cells greater than 5, you're going to be treating this for cystitis. The treatment is going to be trimethoprim sulfamethoxazole. That's most commonly used. That's Bactrim. But we must keep in mind that this is a sulfa drug, so a lot of patients are going to be allergic to it. If they have a sulfa allergy, you go ahead and treat them with a fluoroquinolone, like levofloxacin or ciprofloxacin. Please keep in mind, though, that pregnant women are never treated with a fluoroquinolone. So you will not be treating pregnant women with levo or cipro. Acute pyelonephritis. All right, so this looks like cystitis in many ways. You've got your UTI symptoms of dysuria, burning, frequency, and urgency. What's going to separate these patients from cystitis is that these patients look sick. They've got fever, they've got chills, they're nauseous, and a lot of them come in because they've had nausea and vomiting. So these are patients that have UTI symptoms, but they're also really ill. They've got a fever, they've got nausea and vomiting, and that's generally going to prompt them to get immediate treatment. What's really truly separates this apart, though, is the presence of flank pain. So this is what diagnostically separates acute pyelonephritis from cystitis. If a patient has all of these symptoms and they have flank pain, you're diagnosing them with pyelonephritis. If they don't have flank pain, you're diagnosing them with cystitis. So the flank pain, and of course those sick symptoms like fever, chills, nausea, and vomiting are the thing that separates this from cystitis. We diagnose this the exact same way. We're going to get a urinalysis. Why do we get the urinalysis? Because they have UTI symptoms. We always get a urinalysis immediately in a patient with UTI symptoms. The same way we diagnose this, white blood cells greater than 5. So it's the same way we diagnose it as with cystitis. So patients with UTI symptoms plus flank pain plus a UA with white blood cells greater than 5, that's going to be a diagnosis of acute pyelonephritis. So what do we do with these patients? Of course, in general, patients with acute pyelonephritis are going to appear more sick, and so the question is, do we need to admit the patient? We always admit pregnant patients with acute pyelonephritis, and patients who can't tolerate PO meds because of their vomiting, we're going to admit those patients as well. So outpatient therapy, if we're not admitting them, we're going to give them a fluoroquinolone. And we do that because this is a slightly more severe illness than cystitis. But we can treat them with trimethoprim sulfamethoxazole. That's another option. But generally, it's going to be a fluoroquinolone. If we're admitting this patient, so if they're pregnant or they can't tolerate PO meds, we can do a number of different therapies. Ampicillin and gentamicin is perhaps the most common. That is a very effective regimen for gram-negative infections. We can also use a third-generation cephalosporin, or we can use a fluoroquinolone, but of course we're not going to be using a fluoroquinolone in pregnant patients. So those are all options. And if there's no improvement in 3 days, then we're going to go ahead and get a CT scan because we're going to want to visualize this infection. But we do not get a CT scan immediately. We make the diagnosis from the urinalysis. So the steps are, the patient comes in, they've got symptoms of a UTI, and we know that they've got flank pain because of our physical exam. As soon as we know that they've got the symptoms of a UTI, we get the urinalysis. Urinalysis comes back positive. We decide whether or not we admit the patient, and then we treat them. If they don't improve within 3 days, we get a CT scan. We do not get a CT scan as the initial regimen of therapy. Okay, perinephric abscess. This is a little bit more difficult to diagnose because its onset is a little bit more insidious. So let's start out with what it is. There's a layer of fascia between the actual tissue of the kidney, the parenchyma of the kidney, and the outside of the kidney, the perineum. So because you have that layer of fascia, you can get an abscess in between outside the kidney itself. So this abscess isn't exactly in the kidney, it's sitting outside the kidney. And so what that means is that you may not get UTI symptoms from this because you don't actually have an infection of the urinary tract itself. It's an infection outside of the kidney. Now this is included in urinary tract infections because perinephric abscesses can come from the things that cause other urinary tract infections like cystitis and pyelonephritis. So a lot of these patients that have perinephric abscesses, it's going to be the triad of fever, abdominal mass, and flank pain or abdominal pain. A lot of times, though, this is really an insidious onset of symptoms. So it kind of started out a week or two ago with these UTI symptoms that weren't really severe and they didn't come in. And now they've got this fever that's been going on for a long time, and they got a little bit of abdominal pain. It kind of hurts in their back. You do the physical exam, and they've got CVA tenderness. But what separates them, even though they have CVA tenderness, what separates them from pyelonephritis is that this has been going on a lot longer. They don't have the UTI symptoms as much, and they've got a mass. It's an abdominal mass. You can palpate this from either side, but generally it's described as an abdominal mass. But this generally presents a challenge to diagnose. Another way you can diagnose this is patients who have had those pyelonephritic symptoms and they've lasted longer than 5 days or they're resistant to therapy. That can be a sign of perinephric abscess too. So remember, with the acute pyelonephritis, if there's no improvement in 3 days, a CT scan's appropriate. That's what we're looking for, is the perinephric abscess, because medication alone is not going to treat an abscess. It never does. Well, I should say it rarely does, because you're not penetrating into that abscess. So if a patient doesn't respond to antibiotics and you're treating them for pyelonephritis, you should consider a perinephric abscess. Now, how do we diagnose this? We're going to start out the same way. So urinalysis is always going to show positive white blood cells, but generally these patients are going to be culture negative. So urinalysis remains the best first step. And what we're doing here is we're establishing a presumptive diagnosis. We're essentially using the urinalysis as a screen. So we think a patient might have a perinephric abscess. What do we do first? We get a urinalysis. And the fact is, if we have pyuria and we have a unexplained fever, then we're going to go ahead and do an imaging. And ultrasound is the best initial imaging test because it's cheap and pretty reliable, but CT and MRI are more sensitive. So if you're asked what's the best initial imaging test, you're going to say ultrasound, but if you're asked what's the most accurate or the most sensitive, it'd be either CT or MRI. MRI more than CT. So, all right, so basically, and the reason that I want to bring this up is because this is so similar to pyelonephritis, and the line between them can be blurred, but what should separate this for you is the presence or not of UTI symptoms. So patients with perinephric abscesses generally aren't having the burning, the frequency, the dysuria. Patients with pyelonephritis are. So once we've imaged the perinephric abscess, and that's necessary for diagnosis, then we're going to treat them empirically. So empiric therapy for a perinephric abscess is going to include a semi-synthetic penicillin, and that's treatment for Staph aureus. So that would be nafcillin or oxacillin. And then we also give them an aminoglycoside, so gentamicin is most commonly used. And then we also have to drain the abscess, and that's done percutaneously. So this is going to be a combination of medical and surgical therapy. Asymptomatic bacteriuria. So this is just a coincidental discovery of bacteria in the urine on urinalysis. Like its name, there are no symptoms. And what we see is that on urinalysis, you have greater than 100,000 colony-forming units per milliliter. So this will be a measurement that comes out in the urinalysis, and if it's greater than 10 to the fifth colony-forming units per milliliter of a single organism, then that's considered bacteriuria. And of course, if there's no symptoms, then it's asymptomatic bacteriuria. The diagnosis is established in men if there's just one finding on urinalysis. For women, you have to do a repeat UA and get another finding of 10 to the 5 CFUs per mil. Generally, though, we don't treat this. So asymptomatic bacteriuria is a finding. We note it, but we generally don't treat it. The major consideration and the reason that we're talking about this is because we do treat this in pregnant women. It has to be treated because this can lead to adverse pregnancy outcomes. It can lead to fetal demise. It can lead to premature delivery and so forth. So the way we treat this is just with PO, amoxicillin, ampicillin, nitrofurantoin. All of those are reasonable options. All right, so let's review. So cystitis or bladder infection, these are patients with UTI symptoms and no flank pain. The first step in diagnosis is a UA. You'll have white blood cells greater than 5. We treat them with either trimethoprim sulfamethoxazole or fluoroquinolone. Patients who have UTI symptoms and they do have flank pain and they tend to appear sicker are diagnosed with acute pyelonephritis rather than cystitis when they have the UA with white blood cells greater than 5. So acute pyelonephritis is all the same as cystitis except they have flank pain and they appear sicker. Treatment for acute pyelonephritis, we admit them if they're pregnant or can't tolerate PO meds. There's a large, vast array of things you can treat them with. Trimethoprim sulfamethoxazole, fluoroquinolone, third generation cephalosporin, ampicillin, gentamicin, and so forth. In the inpatient setting, we tend to use ampicillin, gentamicin. In the outpatient setting, we tend to use fluoroquinolones. Perinephric abscess, this tends to be a prolonged fever. They have pyelo symptoms such as flank pain or abdominal pain, but the UTI symptoms are a little less common. But usually this is going to present as an ongoing fever and flank or abdominal pain. Sometimes you'll palpate a mass, and the way we diagnose this initially is with the urinalysis. Again, you're going to have white blood cells greater than 5. Once you've established white blood cells greater than 5 on urinalysis with a fever, then you're going to go ahead and get an ultrasound, assuming that they don't have UTI symptoms, in which case you'd probably be diagnosing them with cystitis or pyelonephritis. If the ultrasound comes back positive, we're treating them with medical and surgical therapy. Surgical therapy to drain the abscess, and medical therapy is going to be a semi-synthetic penicillin and an aminoglycoside in combination. Bacteriuria, asymptomatic bacteriuria, of course there's no symptoms. The diagnosis is with urinalysis, and it's greater than 100,000 colony-forming units per milliliter. The only population that you're going to be treating these patients in on the USMLE is going to be pregnant women. and we treat them primarily with either amoxicillin or ampicillin or nitrofurantoin. And that is it.